appreciate the opportunity to speak with you. And I want to give you first a perspective about why neuro-ophthalmology is relevant here. So my training is first as a neurologist, and then I trained as an ophthalmologist. I combined the two fields, and I've been the director of the neuro-ophthalmology service for the last 15 years or something like that. So neuro-ophthalmology is a field that deals with visual problems. But because it's both ophthalmic and neurological, we see problems that involve the eye or the brain or both. So just in what you've heard today and what we already know, you can see how involvement of neuro-ophthalmology is particularly important in Act 2 because there are problems that are basically related to the eyeball itself and how it functions, and other problems that are neurological. And they come together in this one disease. So we've been really appreciative to be able to evaluate the patients as part of the protocol here. We're still learning as we go forward, and a big part of what we're doing is to try to learn and share, and ultimately work to better define the condition and hopefully treating the condition. So I'd be happy to answer any questions for you as well. But Ryan is also doubly trained. So Ryan is a fully trained pediatrician, a fully trained ophthalmologist, and he's now doing a pediatric neuro-ophthalmology fellowship, but he's going to do yet another fellowship next year in pediatric ophthalmology. But you can see that background and training also completely surrounds the topics related to Act 2. So Ryan has put together a thoughtful and interesting overview of what we see from a visual perspective, and I'll be happy to answer any questions later as well.
Okay. Thank you guys for having us. I'm really excited. We've seen a couple of kiddos with Act 2, and we're excited to talk about what we found and what other people have found that we've compared everything to. So we don't have any financial disclosures for this. So how does the brain see the world? So I'm trying to get this so it goes right. So right now you have the two eyes, and the brain is connected to the two eyes by the optic nerve. And the optic nerve is really like a cable that connects the brain to the eyeball, and it starts in the back of the eye. When the eye sees the world, what happens is about 53% of the fibers from the retina, which is like the antenna for the eye, get crossed at what's called the optic chiasm. So if my fists are the two eyeballs, what happens is right where my wrists intersect is the optic chiasm, which happens in the center of the brain. And then the fibers from the left side of the world, all the vision fibers, go back to the right side of the brain. So again, back to that greater theme of crossing that Patty was talking about earlier. In Act 2, there are really three main ophthalmologic or eye findings that we're going to talk about and have been shown. So the first is something called congenital mydriasis. The easiest way to think about that is the dilated pupil that you all see in your kids. So you can think of that like a camera aperture, is what the pupil does. It controls how much light goes in and out of the eye. Accommodative insufficiency, which is a fancy way of saying near vision. So accommodation is the term that's used for when the eye changes shape of the lens, which is like the magnifying glass that's in the eye. So that lens changes shape so that you can read something up close, or when you're over 40 years old, when you have to start using reading glasses, why you have to, because your eyes can't change shape quite as well, which we'll get into. And then finally, the retinal vascular tortuosity, which I'll get into a little bit later. So if you look at the congenital mydriasis, or the dilated pupils, what you can see is there is iris tissue. That's the colored tissue here. But the muscle that controls whether the pupil constricts is a smooth muscle, so it doesn't work. Or in a lot of cases, when you look at this, there's really no muscle tissue there at all, so it's just not there. So there's nothing to constrict. And even when you put in dilating drops in these patients, from what other studies have shown, other case series have shown, the pupil still doesn't constrict. So light can get in, and there's no way for the kids to control how much light gets in, which is why they're very sensitive to light. And it's one of the things that we can do to help them is increase their access to sunglasses or tilted lenses and come up with ways to help them be more comfortable in whatever environment they're in. Iris anomalies in the ACTA2 mutation have been characterized well. So this is one study that was just recently published in the British Journal of Ophthalmology, where they looked at 16 patients with iris anomalies. So of the 16 patients, 13 of them had something called an iris flocculus, which is a really, really obscure way of saying they had a little bit of extra tissue around the edge of the margin of the iris. That has been shown to be associated with aortic dissections in some conditions, but not actually ACTA2. So 13 of these patients did not have ACTA2, they had the iris flocculus, and they were put into a separate category. Of the 3 patients that actually had congenital mydriasis or dilated pupils, 2 of them had the ACTA2 mutation. So now, more importantly, so this accommodative insufficiency or near vision, how can we help? So the way I like to think about the lens in the eye, so that's that magnifying glass I was talking about, I think of it like a clear gummy bear. When you're born, it's a clear gummy bear. There's no cataract, there's nothing making it cloudy, and your smooth muscles in your eye change shape and contract, and they allow the lens to be squished. And when it squishes, it increases the power and lets a child look up close. So when you're very young, you can put something on your nose and you can still read it. When you turn 40, if you don't have your reading glasses on, there's no way you're reading it. So what happens is, as you turn 40 or as you get older, or in patients who don't have that accommodative drive, that ability to squish the lens, it's essentially like a clear peanut M&M. So it's not going to be, the shape is not going to change no matter how much they try. So how can we help these two things? Because really, neither of these things they're issues that need to be overcome, but they're things that we have answers to treat and help with. So it's more something that we need to be attuned to for all of these kiddos and make them more comfortable. So the first is reading glasses. So depending on what your prescription is, if the children are very far-sighted, so they can see in the distance very well, they're going to need help looking up close, and that's where bifocal glasses come in. And we even, in other conditions in pediatric ophthalmology, we use bifocal glasses to help kids see it near. So it's not something that's, it's not common, but it's not totally uncommon either. And there are lots of reasons that we do it. But it's important for their visual development because remember, a child's world, especially when they're young, is within about 10 feet. So you want that within 10 feet to be in focus for them. So it's important that everyone gets eye exams and we know what their prescriptions are, because if we can help them, they're getting more comfortable in their environment. If they're nearsighted, like, for example, my father is now 70 and he is very much presbyopic, but he's also nearsighted. So when he wants to read something clearly, you see him take off his glasses. So he takes off his glasses because right about here is in focus. So if you're nearsighted or you can see up close and you're young, it's actually a benefit. So the glasses aren't as important for them because their whole world is right here and they can develop by seeing clearly right here. And then you'll give them distance glasses later and then maybe bifocals later, but early on, it's not as big of a deal. One of the important things that, and it's a topic I didn't put on this slide, was that there is a condition called amblyopia, which is again, another very long doctor word that basically means when children are young, they like both eyes to see clearly. And if one image is different from the other image, the image that's better gets preferentially elevated in the brain. And the brain shuts off the pathways of the other eye and in the brain. So it's not an eye problem, it's actually a little bit of a brain problem. And what we do, and these kids need to be identified because we can fix it as long as we catch them when they're young. So up until the age of about 8 or 9, the brain is plastic enough that if we do exercises by patching the stronger eye and letting the weaker eye get exercise and correcting it with glasses, we can strengthen both eyes so they're back together. It's going to affect them for their entire lives. So that's another reason why we need to see these children early and make sure that they have an appropriate correction if they need it, because it can really help keep both of their eyes seeing well for the rest of their life. So that's the reading glasses. The sunglasses. So the other important thing is obviously they don't have the ability to regulate the amount of light that gets into their eyes. And that can be horrifically uncomfortable. Just like any of you, when you go to the eye doctor and get your eyes dilated, you have a big pair of black sunglasses that let you walk out. So allowing them to wear sunglasses and making sure their teachers know that if they need to wear sunglasses in school, they'll actually do better and they'll see better. There can be tinted lenses that can help with light sensitivity that can also help lots of them, where you can still see their eyes, but they're rose-colored glasses or things like that. So just to make them more comfortable and help them a lot. The last part of it is the retinal vasculature. So just like there are blood vessel problems elsewhere in the body, there are findings that we have in the retina that we don't know how significant they are yet. So this is a normal optic nerve from the University of Iowa of a 10-year-old. So this is the optic nerve itself, the head of it, which inserts in the back of the eye. That's the head of that cable I was talking about. And then these are normal blood vessels that have a little bit of curve to them, but not too tortuous. And then a very healthy sheen over the retina. This white is actually the nerve layer reflecting back. So it's normal. And then right here, this is called the macula, which is the 20/20 seeing part of the eye. Here's a picture of an ACTA2 patient. And so you see the nerve is there, it's pink, it's healthy. It's a little bit more red than you would expect, but not abnormal. But you see the stark difference between the two pictures and how tortuous the blood vessels are. We really don't know what the clinical significance of this is. All the patients that we've seen, all the patients that have been reported see very well. They don't have visual issues. But it has been shown that patients who have more severe vascular disease tend to have more tortuous blood vessels in the retina. So it might offer a window, which is what we're working with Dr. Mussolino on, for us to follow either a treatment method or how the vascular disease, like do anything invasive, because with the congenital mydriasis, we don't need to put many drops. They just come in and we take pictures and we can share our information with Dr. Mussolino. So that is kind of the three topics. But the important thing, like I said, is most of the eye findings are not pathologic in the sense of them having lost vision, but really supportive in that there are a lot of ways that we can help them do better in school, help them be more comfortable, help them interact with their environment better, as long as they see an ophthalmologist and we can follow them and make sure they have the correct correction. So thank you guys.
Thank you so much. So you guys have any questions for them? They have to leave, and I do want to give the opportunity for people to ask at least one or two questions.
Can I make a comment before here? Just to show you how valuable it is to meet patients and families and to work with you, right? So just yesterday, I didn't have a chance to talk about this, but as I was looking at the patients, I just had a sense that the eyelids were just a little bit lower than typical, not droopy, but just a little bit less than typical. Huh? So it turns out that the muscle that holds the lid is a striated muscle, mostly. But about 10% of that elevation strength comes from a smooth muscle. So I'm just realizing that, mild ptosis, not the kind of thing that would ever close the eye, but it's just a hint of a lid that's a little droopier than normal. And again, that's just something that, because I've now seen several patients, you just get a sense that you understand what the look is. But anyway, assuming that's true, it's very mild, it won't be problematic, and it won't increase.
And it's wonderful because it makes their eyes very spatial shape, which could be used to put together when the baby's born, spatial shape, day guide, PDA, pupil, PDA, attitude. So this is why we're trying to look at things that are easy to catch, that are in all of you, and not the other kids that do not have attitude. So that's a really excellent point.
In this day of social media, we take a ton of pictures, especially with flashes. We've noticed that every picture that my daughter has, her pupils are red.
Yes.
How do we not avoid it, but
Yeah,
is
sure.
something that we can do to make it better?
Sure, you want to explain why that happens?
Yeah. So, sorry about that. Basically, since their pupils are dilated, what you're actually seeing, the redness, is the reflection of light on the back of the eye. So it's going to be a question of using like a red-free filter and a camera or whatever, adjusting the picture afterwards. Because even people who don't have the ACH mutation, you have pictures, everyone has pictures where their eyes are red because of the lighting or they take it with a flash. So that's the answer. So you just have to, it's a totally normal phenomenon, but you're literally seeing a reflection of light coming back at you from the back of their eye.
You see that in animals sometimes at night, and you can extract that with a lot of the programs allow you just to extract that.
If it's a different color, shouldn't you worry? Like I said, if it's white instead of red.
Good question, yeah, absolutely, yeah. So, yeah, that's a whole topic, but yeah, if you don't see the normal red reflection, at least sometimes, because it depends somewhat on how the light's getting in, the angle, but if you never see a red reflection in one eye, but you see it in the other, yeah, that's a potentially important ophthalmic.
Right. Thank you so much.
Thank you.
For also seeing all
Okay,
of this.
thanks.